Now we're going to go back and hit a few things that we talked about yesterday. We are not going, or on last Thursday, we're not going to spend a ton of time on some of the practicalities that we talked about the other day. Because we really want to start moving forward with the fun stuff in this class. So we talked about the cardiac cells. There's two basic types of cardiac cells. So they have principles, or they have properties, but they also have specific jobs. So you got your myocardial cells, also known as the working cells. These are the ones that are there for the contraction. These are there for the pump. Okay? Then you've also got the pacemaker cells. The pacemaker cells are going to be your conductors. These are the ones that are going to propagate the electrical impulse. So if I told you that a group of myocardial cells formed together to combine and make the SA node, you would know that these are pacemaker cells. All right? Now, some of this stuff that is going to be in this may not match 100% as far as going with the flow in these outlines. These outlines may be a little bit more detailed than what I talked about up here because they're based off of some stuff I've had in the past, but it gives you more valuable information right there at your fingertips. So don't be scrounging around, all right? Things that I tell you in here are going to be in your book, but it's also stuff that may not read word for word verbatim in your book, but it's stuff that I feel like is important for you to know, and I have my own way of telling you how this stuff works, okay? So, on the very most basic function of a pacemaker cell, it's going to have the ability to propagate an electrical impulse and send it down the line. Now, here's what's important about these, though. They don't mechanically contract. Okay? They don't mechanically contract. When we talk about the four principles or the four unique characteristics of a myocardial cell, you've got three that are electrical based and one that is mechanically based. Okay? So excitability, automaticity, and conductivity are going to be the electrical based, and then contractility is going to have to do with the contraction of the heart, the ability to contract. Now, when we talk about contraction as well, though, you're going to have two types of contraction. You're going to have the propagation of the electrical impulse that's influenced by the influx of calcium into the cell. And then you're also going to have the mechanical contraction that is based off of the stimulus of that electrical propagation. Does that make sense? Yes. Don't glass over on me yet. There's a couple of very important terms that we've got to understand once we get into reading arrhythmias. Once we get into interpreting arrhythmias, there's a couple of things that you need to understand so that you can understand how the electrical conduction system works so that you can read these. First term is threshold. Anybody ever have a boiling point? Anybody have that where if we weren't recording, I'd talk about my wife a little bit, how much I love her. Anybody have that point to where you can only take it, then all of a sudden you just explode, right? Well, that's essentially what threshold is. Threshold is for the myocardial cell. It gets the stimulus to the point to where it's received enough to explode. Okay? To explode. All right? That's going to be, the stimulus is going to hit the cell until it receives a response. Okay? Here's the deal. Here's the reason why you can run into some pretty bad arrhythmias. Is because the heart pretty much works on a all or none phenomenon. Because they are all together in a syncytium, because they're all together, they conduct, they contract, they do all these things. If one goes in, they all go in. Alright? It's an all or none phenomenon. It's not really a phenomenon, it's just once they hit, they all hit or they don't hit. The problem with that is that once you get into these where you're starting to have ischemia or issues with the electrical system, and you have cells that want to start propagating an electrical impulse that are not part of the normal conduction system, it doesn't just affect that single area, it affects the whole heart. And what that does is that irritates the other cardiac cells, and then they start hitting their threshold, and then they all start firing off, and then you have things like ventricular fibrillation or even atrial fibrillation and things like that. All right? All right, so we know these four. I think we've kind of hit this in. Y'all should know these. But it's important to know them so that you understand why the things work like they do. Now, these type of tables right here, so my information comes mainly from your Brady book and from your Beasley book, the Understanding EKGs. That's a really good book. I really like that book a lot. So any of these that are in this yellow and blue format, those are going to usually come out of your Beasley book. So, I think we've got a pretty decent grasp on this too. Can you come in and check something? Okay. I think we've got a pretty good grasp on this too, because we've talked about it a good bit, but you've got to understand that the electrolytes play a huge role in the myocardial contraction in the cardiac cycle. So it's not only in the heart, the cardiac cells. Electrolytes play a huge role in the rest of the muscular cells and all that too. Remember what we said about the heart cells? What's unique about them is that they kind of function as both a skeletal muscle and a smooth muscle. All right. Now, I would like for you to kind of understand the anions and the cations or cations, however you want to say it. Don't care as much that you really have the full chemistry down as far as how many positive charges and negative charges and all that. What I really want you to understand is what we talked about the other day. The outside is positively charged, the inside is negatively charged until we have that influx of sodium and that outflow of potassium. Okay? So, three major cations that affect cardiac function. Who says cation? Who says cation? Alright, we'll say cation. I'll go with the majority here. Alright, you've got three that really affect the function. Now, you've got a couple others such as chloride and magnesium that are important. But, as we're going to see in just a little bit when I give you this waveform, you've got to have the potassium, sodium-potassium pump, and then you've got to have a rapid influx of calcium. Except at the AV node, and that will be that will be based off of a slow influx of calcium. Now, I see y'all writing notes and stuff, and that's great. I encourage note taking, but in those packets is a lot of this stuff, so you don't have to repeat. It's fine. Whatever you want to do. We talked about the potential. You got the resting potential and the action potential, and it's all going to be based off the movement of your electrolytes or the non-movement of your electrolytes. If me and whiteboard don't always agree, but since I am recording this, I'd rather write it up here. called Smart Notebook to make Nick look dumb notebook. Oh, it's going to work for me. Alright, so let's just pretend this is a cell. So if we're saying that a cardiac cell is in its resting potential, you're going to tell me that what is on the inside. But you're also going to tell me, even though this is a positively charged ion, is going to be the atmosphere of the inside of the cell is going to be what? Negatively charged when compared to what? The extracellular space. And we know that the primary chemical or the primary electrolyte on the outside is going to be what? Nah. Alright, so that's the resting potential. Now, we know that the heart must be able to propagate a contraction. We know that that's the purpose of it. And so, it goes from the resting potential into the action. And in that case, we know that sodium is doing what? Coming in, and what's coming out? Potassium. So we know that for every 3 sodium that come in, there's 2 potassium that goes out. So there's a much more rapid influx of sodium into the cell than there is an outflow of potassium. Now, we'll look at this again in just a few minutes. So this is your action, and this is your resting potential. When we go from, well, let me rephrase that. When my cell is in its resting potential, it's also known as, or it's thought of as to be what? Repolarized. It's repolarized. So when it goes into the action potential, when we start having movements across a gradient of these ions, then that is known as the start of depolarization. Okay, great. So, in the resting potential, we've got a negative 70 millivolt voltage. What has to happen is that negative 70 goes up to around 0, maybe a little bit more, once that sodium starts bringing its positive charge in, and the potassium goes out. So in the action potential, wow, this is boring, isn't it? In the action potential, or at the start of depolarization, we know that inside of here has got to become positive, outside has got to be negative. Okay, so this is just a cell membrane here, all right, with all this little ganglia and mitochondria and things like that are important. Okay? So the sodium-potassium pump is channels that you've got sodium that comes in and potassium that goes out. Now, they are essentially a lock and key. The potassium is going to only fit in those potassium channels. Sodium's only going to fit in the sodium channels, but they work together. All right? What is required for these to open and close? ATP, energy. All right? Here's what's cool to me about this whole deal is that not only are you going to learn how to take care of somebody with their heart, but you're going to know how their heart works. I like it. Okay? So we've talked about this. We've hit this, depolarization and repolarization. Y'all are going to have this ion shift thing down by the time we get ready for that test. Because it's not that many that you have to worry about right now. Okay? Good? Good. Alright. So again, repetition is important. Resting membrane potential, resting potential. The state of the cardiac cell when the inside is negative and the outside is positive. Action potential, this is going to be your change in polarity. This is where you're going to have depolarization, the poles, positive, negative. Just remember that. When you've got your action potential, you've got a change in polarity. You're just going to have the opposite of what's normal or what's resting. All right, that is normal, but what's resting, okay? So, what propagates an action potential? Well, what was that term that I said just a minute ago that we needed to remember? Starts with a T, rhymes with threshold. 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 So, the whole thing has to reach its cardiac or its threshold, its action threshold. Once one reaches this threshold, it's going to act to the adjacent regions. It's going to act on the neck cells, and we're going to just have the propagation of the electrical impulse. Now, if all of this wasn't bad enough, we're about to look at a waveform that will not be what you look at on the monitor. There's going to be a waveform that's going to explain to you how this works, how this action potential works. So from the start, from the cells in its resting potential, from the start of the resting potential to where we're starting to have our action potential, you've got 4 phases. Technically it's 5 because they count 0 as a number. So it's a 0, 1, 2, 3, 4. Alright? All this is, don't let it be anything more than what it is. It's steps. It's steps that it must go through. It is the check sheet that the myocardial cell must check off on in order to get to a contraction. Just like you've got a check sheet for your IVs. It's just a step-by-step procedure that it has to happen in order for the myocardial cell to contract. Okay? To reach its action potential and get back to its resting potential. It's not a big deal. This is why I told you it's not a big deal, because y'all are like crap. There's a bunch of squiggly lines. Not a big deal. What is this? QRS complex. Huh? Ventricular depolarization. What is this? It's the T wave. Ventricular repolarization, okay? So we know that a T wave is over here. A P wave is over here somewhere. All right? Essentially, what this is with one action potential, the steps it's got to go through in order to form this complex. Okay? Now, it can also work on the P wave as well, but we're just looking at it like this so that you can understand. All right? What we're going to talk about in a little while is that you've got a positive deflection up. This number right here is going to reflect the change in polarity in the voltage. Okay, so we know that negative 70 is much more negative than a negative 20 or a 0, right? So all this is a depiction of what I just mentioned just a minute ago, is that the cardiac cell must go from a negative to a positive state, and this is just a depiction of how it's going from that negative to positive state, okay? It feels like you're about to cry. Okay. You're going to get there. It's all right. So phase 0. Phase 0, okay? The first start of the cardiac action potential check sheet. Step 1. Step 1. You've got to have the rapid depolarization phase. The rapid depolarization phase. So what do we know about the start of depolarization? We know that there's a much higher influx of what? There's a much higher influx of what? Sodium. There's a much higher influx of sodium into the cell. a rapid influx of sodium into the cell and a outflow of potassium. So there's a outflow of potassium. All right? What's going to happen, remember that sodium comes in 3 sodiums to 2 potassiums, right? So you're going to have 1 extra for each time that it goes. So you know that sodium is going to go quicker than potassium. We know that it's going to have a much quicker positive change, a much quicker depolarization. So what has to happen in phase 0? This is where it all starts. This is where it all starts. Sodium comes in very quickly and it sends the inside of the cell very quickly from negative to positive. Negative to positive. Alright? This can only occur when the cell membrane reaches that threshold potential. Alright? These fast sodium channels, they only open momentarily. So the channels know, let's get this rapid influx of sodium in and then stop it. Get just enough that it needs to get in up to this 0 to about positive 20. Okay? And then stop it. Just stop it. Alright? So once we get that rapid charge, alright, so just think of the cell right now as just starting to charge. It's starting to charge, starting to get that influx. It's getting that influx. It's starting to get a lot of energy. It's starting to get very, very positive and happy. Alright? Just think of it like that. Alright? Then we go to phase 1. My mind can't really think. I wish they would have said 0 as 1 and we'd have 5, but that's okay. It's neither here nor there. We've got phase 1 now after phase 0. This is the early repolarization phase. So this is where your fast sodium channels close. So we're done. We're done. There's no more sodium coming in once we get to this 1. Okay? But potassium continues to go out because it goes out a lot slower than sodium goes in. Okay? Once we get to this, we're going to have a decrease in the number of positive electrical charges and a drop in the membrane potential. Don't let these big words go crazy on your head. It's okay. Then phase 2. This is the plateau phase. All right. So since phase 0, we've had a rapid influx, a crazy high charge. Then the charge is starting to go down. So it starts to go down pretty quick. Then all of a sudden, the charge just kind of hangs out for a minute. Okay? Again, this is just the poles. This is just the polarity. Okay? So in phase 2, I just went back to phase 1 so you can see the picture. In phase 2, this is where calcium's going to come in. Alright, so phase 0, we know that what is coming in? Sodium. In phase 1, we know what stops coming in? Sodium. So in phase 2, this is where calcium's coming in. So in phase 2, calcium is coming in. Calcium is coming in phase 2. In phase 2, calcium is coming in. Okay? This is important. When I talked about the other day that it's important that you understand because you're going to start giving medications that will have effects on certain channels. Well, there's medications called calcium channel blockers. Calcium enters through these slow calcium channels and because of its charge, even though potassium's continues to leave the cell, because of its charge, it's going to keep it in a prolonged depolarization state, this plateau, but what it needs to happen is that it's got to have time for muscle contraction to occur. So calcium has a very important role in the contraction. The contraction. Alright? So let's put it together for just a second. If I know that I've got a cell, or if I know that I've got a heart that is contracting very fast, I've got a problem with heart rate. All right? I've got a problem with heart rate. And I give a medication that is a calcium channel blocker. What do you think that medication might do? It might slow it down because it's prohibiting the amount of calcium that comes in. And calcium has a direct effect on muscular contraction. Calcium affects what? Muscular contraction. Okay? The heart is a muscle. The heart is a muscle. So it's very important that calcium influences that muscle. Okay? Then you've got phase 3. This is where you're going to have rapid repolarization. So if you think of depolarization as the inside of the cell is becoming very quickly positive, repolarization in phase 3, very quickly we're going back to our resting potential. All right? We've done the work. We've stimulated muscular contraction. Now we need to rest for a minute. Now we need to rest. Okay?
So the contraction actually happens in phase 2?
Yes. If you look at, let's see if I got it on. All right, yes. All right. If you look right here, this waveform, what is this showing? Ventricular depolarization, right? So if you think of just this affecting the ventricle at this point, a cell in the ventricle, then you see that between 1 and 2, whenever the calcium comes in, that's where you're going to get the squeeze, okay? And then at that point, once we've got the squeeze, we're done, right? We're done with that cycle. We don't need the muscle to contract anymore. We need the muscle to rest for a moment. So that's when, after that, you start going really quickly down to where you get into phase 3 and then phase 4. This is going to be the period between action potentials. This could also be thought of as the cell's resting potential, okay? All right? Okay, I got 9:32. Let's be back at 9:42.
Can you go back to
Sure.
What were you saying about type A? I feel discombobulated because this doesn't match with this and
I'm sorry. I'm sorry. That's just the way it's going to be. I've got 4 years of this class, and it's a combination of all that stuff and then 4 years of materials.
It'll take me a minute to
Yeah. I'd be the
get
same
my
way.
groove.
But they're good. But yeah, pistachio. But it didn't like pistachio butter.
Well, yeah, pistachio. The sort of rapid
Your body should be aligned like
Oh, it's kind of like
get the rest. Get the rest of it. You start having slow release, but at this point it's going to reactivate to get the rest of the potassium in and the rest of the sodium. This has to happen on atrial depolarization and I'll get with you after class about that stuff. Yeah, this. So you would actually have this 0, 1, 2, 3, 4 on the atrial. But if you think about it, the T wave is ventricular repolarization, so that's why on this you see the repolarization. So if we had an atrial, that's why they don't have the T wave right there. But if you took this and just replaced it with a P wave, you would get quite the same thing.
Okay, so it's not necessarily just for ventricular.
Oh no. It's for an electrical cell. Yes, it's for an electrical cell. And that's in all the way down.
really got it because he's like, oh, you're doing this question now, you're doing this question now, you're doing this question now, you're doing this, you're doing that.
Yeah.
And my schedule is it
Was from like I work Monday to Friday. Yeah. Yeah, I know.
If y'all look on in Canvas in 241, there's a tab called Pages, and it has your schedule for the collaborative lab, and it also has your lab groups. Also, we sent the PO up to get you guys your FISDAP accounts because you're going to have Paramedic. So you'll probably keep the same AMT login, I'm not sure, but if you have that and we're upgrading you to Paramedic because there's a couple other things, all those fees are covered when you take class. But once we get those back, we'll get you in, we'll figure that out. All of your schedules as far as your collaborative labs and your clinical schedules, and then also on the peer leadership lab thing, all that stuff will be in FISDAP. So we won't have papers here, there, and everywhere else. Once we get y'all into FISDAP, all that stuff will be in there. What's in the roll? All right. All right. Well, if everybody's back, we'll start a minute early. I like that. All right. So, I'm a cardiac cell. I'm a real cardiac cell. And right now, I'm starting to get the threshold activated. I'm starting to get an influx of sodium, and I'm starting to get it, and it's feeling so good, and I'm just about... There's a bunch of sodium that's coming into this cell, and I'm about to get ready to have... a cardiac cell is about to have a lot of sodium come into it, okay? And it's about getting ready to have its action potential. It's got for every 3 sodium, it's got 2 potassium going out. What phase is it in right now? Lots of sodium coming in. 0. Okay. All right. So, this cardiac cell, it starts getting lots of sodium. And it's about to hit that threshold. That threshold is going from a negative 70 to a positive 0 to a positive 20. All right? Once it gets its threshold, it tells the sodium to stop. And we start having a slow release of potassium. And we start having a little bit of sodium leaking out. What phase is this in? Phase 1. All right. So right now, what we've done is we've changed the polarity from the outside to the inside. So phase 0 to phase 1. All right. So now, I'm full of sodium. And I want to share it with the muscles. I want to start making the muscles move. I don't want to share the sodium, but I want to share the feel-good that I got. But it's going to take a little bit of what to make those muscles contract? Calcium. All right? So right now, I'm kind of hanging out on my polarity. I'm just kind of there. I'm still a positive polarity. But now I've got an influx of calcium. Calcium is very important to do what? Have muscular contraction of the heart. What phase am I in? 2. All right. So now we've had that calcium come in, and now we've made those muscles contract, and now we're getting ready to take us a little short vacation break. So now everything's just going out, and we're just going down quick, and we're just laying there. What phase is it where I'm going down quick? Phase 3. Phase 3. All right, so everything's kind of left out. Now, there was a question about phase 3 because it said, I thought it says right here that the sodium-potassium pump is activated. Yes, it is activated again to get the rest of the sodium out and the potassium to come back in. Okay? So now we've gotten past phase 3 and we're just laying there lighting us up a cigarette and chilling. All right, what phase is that? Phase 4. All right, don't really light up a cigarette. That'll give you cancer. All right, phase 4, also known as the resting potential state of the cell. Okay? Now, as far as that goes, I want you to have a basic understanding of that, kind of understand how it works. We're going to talk about it, and then we're going to move on. All right? This is important here. You've got what's called a refractory period. So, think about this. When you're working all day long, you just need to rest. You just need to rest. So you just want to sit down in your chair and have nobody bother you at all. All right? That's going to be the refractory period, is when you're trying to rest. When the cardiac cell is trying to rest. Okay? Now, I have a 4-year-old at home. She has no respect for a hard day's work. She doesn't know what that means. So when I sit down, I think I'm good, but then she's coming, and now I've got to start working again. I've got to start doing something. All right? But it's not going to be to my full potential, and if she says the wrong thing to me or she acts up, then I'm going to go crazy on her for a few minutes. All right? That would be the relative refractory period. But let's just say that I go home and I sit down and I just plug my ears up, and nobody bothers me. So I cannot be acted on by any stimulus because my eyes are closed and my ears are shut off. You can't tell me anything. I'm not going to do any work. That would be the absolute refractory period. Okay? So the cardiac cell has a refractory period. It has the absolute refractory period and the relative refractory period. I'll give you another analogy in just a minute. The absolute refractory period occurs during the peak of the... Wait before you write that down. Yep. Okay. The absolute refractory period occurs during the peak, the start of the QRS, all right, to the peak of the T wave. Then the relative refractory period is from the peak of the T wave to where we get to resting potential. All right. Now, why is this important?
From the peak of the QRS to the peak of the...
From the start of the Q, all right, to the peak of the T. All right. In the absolute refractory period, this is the time where the sodium's coming in, then going out, and the calcium's coming in. We're actually having the contraction. During this time, it cannot be acted on by any type of outside influence. It's all or nothing at this point. You can knock on the door, but it ain't going to let you come in. I'm still referring to a myocardial cell. I'm still referring to what we were talking about just a minute ago. It can have a stimulus knock on the door, but if it's in the middle of this depolarization, it's not going to let you in. Then you have the relative refractory period. All right. So this is down to about the last third of the decline phase, phase 3. All right, until we get to the point to where it's ready to recharge again. Okay. This means the relative refractory period means that it can be acted on by an outside influence. But if it is acted on, it is not completely back to its resting state, so it's not going to be able to give its full contraction. Now, one of the things that we know about a cardiac cell is that it is irritable, or it gets excited easily. You start getting outside influences on the cardiac cell as it's trying to rest, it is going to become irritable. Now, it's one thing for me to become irritable with my little girl and just say, go to your room, go to timeout. But if your heart starts to become irritable when it's acted on in this relative refractory period, it can start throwing some fatal arrhythmias. All right? You can see what's called the R on T phenomenon, where you notice this T right here. If I start getting an action potential starting while it's trying to relax, I may actually have the start of a contraction all the way to where I get to an R wave, and the R wave hits on that T as it's trying to relax, and then that goes into a fatal arrhythmia. Okay? Just tuck that R on T phenomenon into the back of your head right now. Just tuck that into the back of your head. Think of the refractory period as a toilet. Alright? What happens when you flush a toilet? When you pull the handle, what happens? Water flows out, the tank empties, right? What happens when you start, and nobody get literal on, well, there's tankless toilets and stuff. I'm talking about the old-timey toilet and things like we got now, okay? What happens if you start letting that tank, or what happens if you start to jiggle the handle immediately after you flush? Are you going to have any other kind of flush? No, you're not, right? But what happens after you start letting that tank get a little bit more full, a little bit more full? Are you able to activate a flush? Is it going to be a full flush? Is it going to do what it needs to do as a toilet? No. So think of that as the absolute and relative refractory periods of the cardiac cell. Whenever the cardiac cell fires, the absolute refractory period is going to be during that time where it cannot be acted on. The handle's being jiggled, but nothing's happening. The relative refractory period is a time where the tank's filled up just a little bit, and now you're jiggling the handle, and you're just getting a very weak flush. You're going to get a very weak contraction, but unlike if you flush the toilet before it's full, that won't kill you. It will kill a patient if they start having those kinds of issues. All right. We got to move on. Some important terms to remember when it comes to these cells is a syncytium. They are grouped together to function as a unit. You've got your atrial syncytium and you've got your ventricular syncytium. Why is that? Why is it important that they're grouped together to where they receive the propagation at the same time and they contract at the same time? Why is that important? So they work together and create a good squeeze. Atria ventricle, atria ventricle, atria ventricle. Alright? Think we know about the polarized states at this point. When we start talking about reading and interpreting rhythms, we're going to talk in milliseconds. All right? We're going to read strips on milliseconds. So all this occurs in less than a second. A full cardiac contraction occurs in less than a second. All right? Full cardiac cycle, less than a second. All right? I don't care that you know these numbers as much right now, or ever really at this point, because there's other numbers that you're going to have to learn here in just a few minutes. So just to review quickly, absolute refractory period cannot respond to any electrical stimulus at all. So that's that first part of the toilet jiggle. Relative, it can respond, but it will cause a premature contraction. Okay? That ain't good. That ain't good. What we want is we want depolarization, we want phase, 0 all the way to 4 to occur without any other stimulus acting on it. We want a full cardiac cycle to occur, which is what's occurring in most of us right now, if not all of us, unless any of y'all have any kind of electrical disturbances that you're taking medicine for. It should occur where we're all just having a complete cardiac cycle with each beat, okay? So, there's going to be a couple of terms that I want you to tuck into your mind that we're going to talk about more when we get into rhythms, but you need to know these base terms. When we have normal firing, SA to internodal to AV to bundle his to bundle branches to Purkinje fibers, all right, that is a normal conduction. But again, remember, we've got unique characteristics of heart cells where they can propagate their own electrical current. Anytime that something occurs outside of the normal conduction system, that will be identified as a ectopic beat. When the heart contracts from cells other than those in the SA node in the normal pacemaker conduction system. Okay? When we see this on the monitor, this will be called an ectopic foci, or an ectopic focus for one. Put it in something that most of y'all are probably familiar with. I've got a QRS, PQRS, T complex, and I've got a PVC. Premature ventricular contraction. All right. Some of y'all may experience that on a daily basis if you drink lots of caffeine or on stimulant medications or things like that. Okay. This would be identified as a complex that is originating somewhere other than the SA node. And remember last week I asked you, how would you know that something's originating in the SA node? You would have a P wave. Remember, P wave indicates what? P wave indicates what? Atrial depolarization would be shown on a rhythm strip as a what? P wave. Okay? Now that's not the only type of ectopic foci, but that is one that's probably the easiest to understand. What's happening there is that a pacemaker cell in the ventricle has decided it needs to fire. It is being acted on by an outside stimulus, and it needs to fire. So it's firing in between. All right? You could have it anywhere. You could have atrial, junctional, or ventricular. I'm not going to get into the details of that because we will get into atrial, junctional, and ventricular rhythms, and you'll be able to understand that better. But if I were to ask you right now, one person answer me, don't be afraid, what is an ectopic foci? What would you tell me? One person, tell me. Something firing not from the SA node. All right? It could be a PVC, but I'm talking about what any type of ectopic focus is, and that's anything that originates other than in the SA node and in the conduction system. Okay? Ectopic foci can be generated by two different types. By something called enhanced automaticity and reentry. Woo. Big words, big words. Now, here's the thing about the heart. It has, what we talked about last week, it has the inherent ability to take over pacemaker site if one of the pacemakers is not functioning. So if the SA node quits functioning, the AV node will take over. If the AV node quits functioning, then the ventricular conduction system will take over. Right? Remember that? Seen this? Heard about this? Yes, that's right. So, you may see ectopic foci as a result of a junctional rhythm or a rhythm that is taken over by the AV node, the AV junction. Okay? Or you may see ectopic foci that as a result the ventricles are taking over as the pacemaker. You don't want to see either of them. But if you do, that could be there. That would be the term we would use, okay? So Nantz automaticity. Essentially what this is that from an outside influence, you've got an acceleration in depolarization. Alright? So that's going to cause the acceleration of the sodium to go in really quickly, potassium start leaking out, the calcium to come in really quickly. Okay? Now we would see that in the monitor, but then we would also check the patient mechanically. We would see that, okay, I've got this that, let's just say that we've got a tachycardic rhythm, a very, 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 very fast tachycardic rhythm. I may see that on the monitor. I'm going to check mechanically to make sure, all right? And then I would give medications that would treat appropriately, okay? So all that I'm saying right here is that you may start seeing complexes. You may start seeing things on the monitor that are not a normal Q or a normal sinus rhythm. These are ectopic foci. These ectopic foci, these rhythms that are anything other than a sinus rhythm, normal sinus rhythm, could be created by any of this right here, all right, medication toxicity, excessive release of epinephrine, norepinephrine, things like that, infarction. Cardiac cells aren't getting oxygen. They're going to become irritable. Electrolyte abnormalities and other medications, okay? Here's the thing. This stuff goes hand in hand. And so it's going to be easier to understand once we get into the rhythms, but you've got to kind of have these words tucked into your mind before we get in there, because we're going to talk about rhythms that are reentry rhythms, all right? Or disorders that are disorders of reentry conduction. You got to know what reentry means. And essentially what this means is that normally conduction occurs through that normal pathway, right? Well, let's say that that electrical impulse is going down the highway and it comes to a block. It knows that where this blocked off, it still needs to stimulate the myocardial cells in that area. But it can't get in through this way. So what's it going to do? It's going to hit the block. It's going to turn around. It's going to go back around through everything. Sorry about that. And then it's going to find its way to go back through that block the other way. Okay? It's going to find its way to go back through. And that will be reentry. It is re-entering into that area. Okay? Now, the thing about it is that sometimes you may not be able to re-enter. It may be so dead at that point that you're not getting anything. But that's not what we're talking about right now. All right. Reentry may produce a single or repetitive ectopic beats. Okay, so ectopic beats are created by two things: accelerated automaticity or enhanced automaticity, or reentry. Reentry. All right. Good gracious. It's okay. Promise. This is what I was talking about. All right. Let's pretend this is a Purkinje fiber. All right. This is a single fiber that's wrapping around to stimulate ventricular contraction. All right. Under normal circumstances, that electrical impulse is going to go down, bifurcate, follow, make sure that these are the cells right here are stimulated, and it's going to continue down the pathway. All right. Well, reentry says that, okay, I'm going down and I've bifurcated. This side is clear, but this side, for whatever reason, I've got a block. It may be a bundle branch block, it may be a fascicular block, it may be any type of block. But what has happened is that I cannot get through this area here. So what am I going to do? I'm going to turn around, I'm going to come back through here, and I'm going to hit back up through there. All right? So look at this, but also imagine cardiac muscle all around this. All right? Imagine cardiac muscle all around this. This is electrical stimulus that is stimulating this cardiac muscle to contract. Alright, right here, there's still cardiac muscle right there. It's got to receive that stimulus, but it's not able to hit it through that block right there, so it's going to come back up and it's going to re-enter. Alright, but here's the thing. This is actually going to be a delayed, something that's delayed, okay? And we'll see that on the monitor. Alright, so if everything's just functioning normally, we're going to have a good QRST. Alright? But in this case, I've got this, I'm going to have a good complex, except for here, and I'm going to slow down, and that's going to show on the monitor, alright? For instance, if we're talking about a bundle branch block, you may hear medics talk about, well, you can identify a bundle branch block by rabbit ears. Alright, you see it, and you see rabbit ears, okay? It's not always the case, but that's a good example. A bundle branch block that they're talking about with rabbit ears would look like this. You've got your T-wave, you've got your QRS, alright, and then you've got another QRS, and then you've got a T-wave, alright? So this is one ventricular contraction, that is two ventricular contractions. So the first QRS would be the result of the electrical stimulus going straight down. The second one would be a delayed contraction due to the re-entry mechanism here, alright? I know some of y'all are glossing over. We'll work through it, I promise. Let me encourage you. This is the first time that you're seeing this. Alright. I don't want you to get into that right now, okay? Sometimes it may take different pathways. Just know that the heart has the ability to hit those blocks and find another way to circulate that electrical current, okay? Maybe due to blocked impulses from ischemia, there's also drugs that would block it, things like that. Don't get too worried about it right now, okay? Don't get too worried about it. Alright? So, that was just a quick overview of some things